Good afternoon, everybody. Today is September 27th, 2019, and it's Fridays with Feldman. We haven't been around since before the summer, and now we're coming back to talk to you about some really specific orthopedic conditions and some very unusual conditions, but perhaps the ones that we treat here at Paley Institute. So today I wanted to discuss with you mostly the achondroplasia spine, or the spine in patients with achondroplasia. Achondroplasia is obviously the most common dwarfing syndrome. And the biggest problem for patients who have achondroplasia as they get older is their spines. Perhaps as children they have bow legs and other problems as well. Something called spinal stenosis or compression of the spine. So I'm going to take you through initially what I think of how you initially treat children with achondroplasia. With achondroplasia have to have spinal problems when they get older. Complications, but certainly it is doable and treatable. So I'll start with, if you can see this, my laptop in front of me. We know that skeletal dysplasia encompasses a number of different dwarfing syndromes, such as achondroplasia, things called pseudoachondroplasia, metatropic dysplasia, dystrophic dysplasia, but today we'll stick to achondroplasia, which is the most common. So in achondroplasia, when the children are born, the foramen magnum, which is the place where the spinal cord exits the skull, is often compressed. That's the spot that get compression. That can cause sleep apnea in children, can even cause sleep apnea as you get older. And that may need to be treated at a very young age, usually by neurosurgeons, not by orthopedic surgeons, such as myself, with a decompression. They open up the area. It is like a car going through a tunnel they cannot fit. We have to make that tunnel bigger. And so they make the tunnel bigger for the spinal cord to fit through, and this often treats the problem. And this should be checked very early on, even in infancy. And I've encouraged my patients to have this checked by sleep studies, make sure that they don't have sleep apnea as babies, and make sure we check the MRI to make sure they don't have foramen magnum stenosis, meaning that up above they don't have stenosis. The next thing that achondroplasia, and we have to know about achondroplasia, is that they should not be sitting up. That basically in childhood, they sometimes are very weak in infancy, and they may not ambulate until 18 months to 2.5 years, and therefore we really shouldn't force them to be upright, because this will cause the problem of kyphosis. So spinal stenosis, which is the achondroplasia problem that we get as they get older, anywhere from age 8 onward, they can get anywhere in their spine, it can become tight. And that tightness is called spinal stenosis. Often what will happen is the child or the adult will be walking and will need to sit or will squat to open up that spinal canal so we can breathe, so they won't have spinal pain or get tired. This is called spinal claudication. So basically that's called stenosis. Achondroplasia does not usually get scoliosis, but they do get kyphosis, that hunchback in their back. That's a problem. It can be avoided if we don't insist that the infants sit up and we allow them to lie back and only sit up and stand up when they're ready to get up. And we can avoid the kyphosis. So it's a slow progression in neurologic problems, often just beginning, as I said, by squatting down, and then more squatting down, then less walking, then frank weakness, and I've seen many patients present with frank paralysis. And that's too late, and we can avoid that. So how do we avoid that? What do we do and what can we do? So the area in the spine, if you can see this, is called the lumbar spine. And this is the spine that's most commonly involved, the lower back, with a tight spinal cord. The spinal cord's in orange, and the pedicles in children or adults with achondroplasia, where the bones are very tight around that spinal cord. So if it's just tightness, we can do what's called decompression. If it's also kyphotic, if it's also round, we may have to put rods and screws in there. And this is just the terms that we use for why they have that. They have thickened lamina, they have hypertrophic ligamentum teres, they have very shortened pedicles. But all these words just mean the spinal cord doesn't have the room to move. The biggest problem becomes when the children enter their teen years, into their 20s. And I have seen too many children and adults from around the world who basically present to me paralyzed already. That is avoidable, truly avoidable. Just pictures of what that means. And this is the area, if you can see what I'm pointing to, that is the area of the spinal cord, and that area is very tight around the orange right over here. So again, those areas can be the areas of spinal stenosis, both in the neck and in the brain and in the lower back. And so we talk about what the indications are to opening up that tunnel, to decompression. Well, certainly apnea, and a baby can do it. If there's any evidence of cord compression on the MRI, or if someone has signs that their neck, spinal cord is being compressed. But when we look at blogs, when I look at blogs from around the world of achondroplastic patients, they're often disabled from their spine, and that is not necessarily what they need to do. And so this is what it looks like if you waited too long. There's the normal spinal cord. This white means there's damage to the spinal cord as it exits the brain through what's called the foramen magnum, and there's already been damage there. That can cause problems, global weakness, problems in breathing, apnea when they sleep, and all kinds of issues. There's the kyphosis. That's the round back of an infant with achondroplasia. We don't have to sit them up. That's how we avoid the problems. They have poor muscle tone, these children, and therefore we can modify their sitting, get them a brace if they need to, and obviously operate if we really have to. But here's a child who already has that kyphosis and is already much older. Well, that kyphosis is also causing compression of the spinal column and of the spinal nerves. And therefore, this patient may end up with a spinal fusion and a decompression. There's the rods, and you decompress, open up the canal. We just did one a couple of days ago, and basically, patients do quite well usually from this if we can balance the spine, which is not always so easy. And again, these areas become quite compressed and can lead to paralysis. And so we try to do this quite early on. And I don't know if you can see, but there's the normal spinal cord brown coming down, and there it is being compressed into the white. It's being pushed by both the roundness of the back and the tightness of the area. So what are your symptoms? What do you have if you have achondroplasia and you have stenosis or you have problems? You could have low back pain. More often you get leg pain. You could also have some numbness. All of us, our legs fall asleep, but not constantly. We can have painful numbness, which is called dysesthesias. Paresthesias are when your legs fall asleep or you're numb. Heaviness of the legs. You can't hold in your urine. That's a big problem. You walk a few blocks and your legs get really, really tired, called neurogenic claudication, and it's all relieved by squatting down. That would mean as an achondroplastic person that I have spinal stenosis until proven otherwise. So we ask people that when we do corrections of, let's say, the bowed legs of an achondroplastic patient, or if we go ahead and lengthen them, we ask them, are you weak? Do you have problems going to the bathroom? Can you limit how far you walk? Are you squatting after you walk? Does that alleviate your pain when you squat? And if all these are true, then we know we really need to get an MRI and look into the spinal problem. And then it depends upon what you have. If you need rods, screws, decompression, fusion. That's just technical. The bottom line is you're opening up the space and at times putting these rods in to hold the spine and welding it together so it doesn't come back again. So that basically is how we treat achondroplasia. I think it is important, really important, to get out there in the Little People of America, in the patients, in the blogs with achondroplasia, saying it's not inevitable. You don't have to live a life of constant spinal pain, constant weakness. It is treatable. And that doesn't mean it's easy, but it is treatable. So today I certainly can take questions, live on Facebook as we sit here, which is usually unusual, or feel free to contact us on Facebook, or feel free to email me at the Paley Institute. It's dfeldman@paleyinstitute.org. Paley Institute is one word, P-A-L-E-Y Institute. And we certainly try to take your questions and try to answer them from around the world here in taking patients I'm standing on a pedestal now and talking to people about the fact that you don't have to live with this. Now, obviously, if it's already paralyzed, then it's very often hard to catch up. Otherwise, we certainly can prevent some of the problems and treat many of the problems. So that's a brief summary of the achondroplastic dwarf spine, or the spine of achondroplasia. And I'm really happy to take any questions. Fridays with Feldman, signing off on September 27th, 2019 from Paley Institute in West Palm Beach, Florida. Thank you. So I'll ask my people sitting if there's any questions, and if there are no questions, I'll ask you all to have a great weekend. Are there any questions?
No questions.
No questions, so we'll be signing off right now, and we hope to hear from you soon. Take care.